The topic is autoimmune diseases and rheumatoid arthritis complicating pregnancy. I'd like to invite the chairpersons for the session, Dr. Professor Radhamani, Dr. Professor Krishnan Karta, Dr. Joseph K. Joseph, and Dr. Manoj Jose. Over to you, chairs.
Good morning, everybody. I, on behalf of my co-chairs, thanks the organizers of this meeting for this excellent presentation which you are going to hear. Systemic lupus erythematosus is one of the most important disease, mainly in women. And the active disease, when the patient is in active disease, there is every chance of the patient having a conception is causing lupus nephritis. If you want to have a pregnancy in a patient with systemic erythematosus, should have a remission of at least minimum 6 months before the patient going to be conceived. And otherwise it will have problems. And the main problem is between how to differentiate between the pre-eclampsia and a lupus nephritis. I think Dr. Midhun is going to give us an excellent talk on this, and there's a lot of problems, a lot of unexplained things are there. Dr. Midhun, please.
Thank you, sir. First of all, I thank the organizers for inviting me, and it's also a great privilege to talk after Madhu's first talk. And coming to my topic, although the theme of this CMA is emergencies in pregnancy, I'll be talking in general about the autoimmune disease in pregnancies, basic principles, so that if you know that, you can avoid medical emergencies of autoimmune disease in pregnancy. And objectives of my talk: how the autoimmune diseases sort of affect the pregnancy, and what precautions needs to be taken, and how to follow a SLE pregnant lady, which is based on a case-based discussion. Because there are a lot of autoimmune diseases. There will be difficult, because of lack of time, I cannot cover all the autoimmune diseases. Therefore, I discuss in detail in SLE and pregnancy with the help of a case. And I also will touch upon the rheumatoid arthritis and pregnancy, and very briefly about other autoimmune diseases like psoriatic arthritis, Takayasu arthritis, spondyloarthritis, MCTD, like that. And most importantly, I will be covering the safety of anti-rheumatic drugs in pregnancy, and also about the accidentally detected ANA in pregnancy without any features of autoimmune disease. What to do, that also will be covered. And this is in general the diseases which I will be covering. And you know that autoimmune disease can affect pregnancy. Similarly, pregnancy can also affect the autoimmune diseases. The common example is SLE. In pregnancy, SLE disease activity can worsen. And SLE can affect the pregnancy also, because there's an increased risk of abortions, preterm deliveries, eclampsia, like that. Whereas in rheumatoid arthritis, actually, most of the cases, the pregnancy actually improves the rheumatoid arthritis disease activity. And the pregnancy outcome is almost like a normal general population. And now let's go to the case, because I will be discussing the case of a SLE with, of a lady who is planning for a pregnancy. And this is a case of 25-year-old lady. She is a known case of SLE, and she got recently married. And now she wants to know whether she can conceive. Is it safe? And just a background of the patient. She is a case of systemic lupus erythematosus with renal involvement, diagnosed at the age of 21 years. That was almost 4 years. And the renal biopsy showed a class 3 lupus nephritis, and the autoantibody profile showed a high DSDNA. And what treatment she received? She received high-dose steroids, mycophenolate mofetil, and hydroxychloroquine. And the current medications include prednisolone of 5 mg per day and mycophenolate, 500 mg BDA, and hydroxychloroquine. And at present, she is clinically asymptomatic and normotensive. When a patient asks such a question, whether she can become pregnant, a SLE patient asks question, these are the usual questions usually pass through the physician or the doctor's mind. And although patient wants to know all these questions, doctor also may not be able to clearly tell what whether she can become pregnant or not without knowing these things. Therefore, first thing is whether a lupus patient can become pregnant. Second question is there any risk of SLE flare during the pregnancy? And is there any risk to the baby? Are SLE medications safe during pregnancy? And how to identify SLE flares during pregnancy? Because some of the like a preeclampsia can mimic a SLE lupus renal flare. And how to manage SLE flare in pregnancy or postpartum period? If you know the answers to these questions, you can actually tell a correct answer or a patient's satisfactory answer to a patient question. And in the next few slides, I will be covering these topics. Can she conceive? The answer is yes. And the fertility is not affected in SLE. Exceptions include if the patient has a renal failure, those who have received cyclophosphamide, there is a chance of ovarian toxicity. That chance is less than 5%. And if the patient has a very high active disease, SLE active disease, that reduces the fertility. And high-dose steroids also reduces fertility. And what are the pregnancy risks in SLE patient? All lupus pregnancies should be considered a high-risk pregnancies and managed accordingly and should be monitored very closely. And as I already told, SLE disease activity can worsen during pregnancy and postpartum period. You know that SLE sometimes can be a life-threatening disease if the major organs are affected. Therefore, this point is very important. And next is the risk to the baby. There is a risk of pregnancy complication, risk of abortion, increased risk of eclampsia, preeclampsia, increased risk of IUGR. And also, you know that there is a entity called neonatal lupus, because if patient has antibody like anti-SSA or SSP that can pass through to the fetus, and it can cause a neonatal lupus in the fetus. It can cause complete heart block and a neonatal rash also. And other risk is the teratogenicity of the drugs which we use in treating SLE. And sometimes, although I said the yes to the patient's question of whether she can become conceived, there are some exceptions. In some conditions, you should avoid pregnancy. The main contraindication includes the severe PH, severe ILD, patient has advanced renal insufficiency, advanced heart failure. And also pregnancy should be deferred for some time if patient has very active disease, a severe disease by the last 6 months, or patient has a stroke in the last 6 months. Therefore, the timing and planning is crucial when you plan pregnancy in SLE patients. And active SLE at the time of conception is the strongest predictor of adverse pregnancy outcomes. That means if patient has an active disease when they conceive, it is likely the patient likely to have complication during pregnancy and postpartum period. And the principle is that, as Madhusudan sir was telling, like epilepsy should be controlled before pregnancy. SLE also, most of the autoimmune disease should be in remission or at a low disease activity on stable drugs for at least 6 months prior to planning for pregnancy. And dose of steroids should be less than or equal to 5 mg per day. And what other disease assessment should you use prior for planning for pregnancy? You should assess for any activity. Although patient may be clinically, they say that doesn't have any issues, you should specifically look for clinical symptoms like oral ulcers, active oral ulcers. You should ask for history of weight loss. Those type of clinical history is very important. And patients should be well educated about the risks of the pregnancy and what all things they should take care of. And therefore, the pre-conception counseling is the important part or very crucial. And investigation, the baseline investigation should include the routine blood investigation along with the urine routine, especially in this case, our patient has a lupus nephritis. You have to look for the activity, renal activity. And echo is optional. If you're suspecting a pulmonary hypertension, you can go ahead with echo. And complement levels, especially C3, C4, usually we do because that low C3, C4 is considered as a active, serologically active SLE. Therefore, C3, C4 should be normal for the last 6 months. That's a prerequisite for before becoming pregnant. And ANA profile, if it is not done recently, that done more than 1 year back, you should repeat ANA profile. Basically, to look for the presence of anti-SSA and SSB antibody, because the presence of that antibody increases the risk of neonatal lupus. And SLE patients, you know that they can have antiphospholipid antibody syndrome, we call secondary APS. Therefore, all SLE patients planning for pregnancy, you should do the APLA workup. And a little bit in detail about what is neonatal lupus. As I told, anti-SSA and SSB antibodies increase the risk of neonatal lupus. After 16 weeks of gestation, these antibodies cross through placenta to the fetus, and that can cause heart block. 2% of the fetus can have a congenital heart block in the first pregnancy. If already one boy or one baby had a heart block, the second pregnancy risk increases to 13%. Therefore, how to monitor? Because if you detect this early during the pregnancy period, we can actually reverse it. Therefore, the fetal echo you should do starting from 16 weeks and every week till 26 weeks, thereafter 2 weeks. By 2 weeks you have to do the fetal echo to see for any evidence of fetal heart block. And the treatment of fetal heart block, if it is a second degree heart block, you should start dexamethasone 4 milligram per day. Should give to the mother. It will cross through the placenta and the baby will get the dexamethasone. With a complete heart block, then no point in treating. And neonatal lupus rash, when the baby is born, they can have some rash. It is called neonatal lupus rash. It is a self-restoring rash, no need of any treatment. And how can you prevent this complication? Yes, the studies have proven that hydroxychloroquine, if you start in pregnancy, it can actually reduce the risk of neonatal lupus. In fact, in all SLE patients, we give HCQ, and in pregnancy, it's a must. And it improves the pregnancy outcome. Also, reduces the risk of lupus flare during the pregnancy and postpartum period. And the antiphospholipid antibodies, you know that there are 3 antibodies: beta-2 glycoprotein, anticardiolipin, and lupus anticoagulant. And how you manage? If SLE patient with antiphospholipid antibodies in a moderate to high titer, moderate high titer means 40 and above in the units of anticoagulant beta-2 glycoprotein or lupus anticoagulant positivity. In those patients, you should give low-dose aspirin along with HCQ. HCQ is there for our patient, therefore you should add low-dose aspirin. If the patient already had prior history of with satisfying obstetric APS criteria, that patient should be given prophylactic low-dose heparin along with low-dose aspirin. Patient with definite APS and previous thrombosis, it is whenever the pregnancy is confirmed, change warfarin to the low molecular heparin along with low-dose aspirin. And most importantly, what is the safety? Our patient is receiving mycophenolate mofetil. Is that drug safe in pregnancy? The following are the drugs which are contraindicated in pregnancy and lactation. Most of the drugs which are contraindicated in pregnancy are also contraindicated in lactation. First one is the methotrexate. Ideally, when a patient is on methotrexate, you should stop methotrexate at least 12 weeks prior to the pregnancy. and patient should be started on folic acid 5 milligram per day daily, not 0.4 milligram per day. We have to give 5 milligram per day because methotrexate persists in the body for a longer period of time. We have to give a higher dose of folic acid because methotrexate is an antifolic agent. And mycophenolate mofetil you have to stop at least 6 weeks prior to pregnancy. Cyclophosphamide, now that it's a very teratogenic drug, it should be stopped at least 3 months prior. Leflunomide is also contraindicated in pregnancy, and a cholestyramine washout is recommended. And tofasnib and other JAK like rifampicin, which is the new molecule for treating rheumatoid arthritis. Sometimes in rare cases also SLE also it is used. That should be stopped at least 4 weeks prior. It's basically because of the scarcity of data of tofasnib or the JAK in pregnancy. Apremilast, which is a drug used in psoriasis, it should be stopped at least 2 weeks prior. And which are the drugs then safe in pregnancy? Hydroxychloroquine, sulfasalazine, azathioprine, cyclosporine, tacrolimus, prednisolone in doses less than or equal to 5 milligram per day. And ideally it should not go above 20 milligram per day. And IVIG is very safe. Colchicine is also safe. NSAIDs, usually we prefer short-acting NSAIDs, non-selective NSAIDs like ibuprofen. And after 28 weeks, we don't use NSAIDs, as you know. And biological drugs. Biological DMARDs, which are monoclonal antibodies, which have been used in refractory cases of autoimmune diseases. You should know at least some of the biologicals. The etanercept, adalimumab, infliximab, they are the TNF alpha inhibitors. They are considered safe in pregnancy, throughout pregnancy, but if you are planning to give throughout pregnancy after some TNF inhibitors that etanercept, adalimumab will pass through the placenta and close to the fetus will get some amount of the drug. Therefore, it will persist in the newborn. Therefore, if you give some live vaccines like BCG, there are case reports of disseminated tuberculosis. Therefore, if you are giving throughout pregnancy, you should avoid live vaccines till 6 months, when the baby attains 6 months. But if you want to give live vaccines, you can stop, like in low disease activity, you can stop at 32 weeks, then live vaccines can be given as per the schedule. Rituximab is usually avoided during pregnancy, but can be used in severe cases. There are other biologicals like IL-6 inhibitors, anakinra, secukinumab, ustekinumab. They can be given if there are no other alternatives. And in lactation, all these biologicals are safe. It's also important to know whether these drugs are safe in males also, because infertility, when the patients come for infertility, sometimes the male may be taking these drugs. Therefore, they may ask these questions. It is said that even the drugs which are contraindicated in pregnancy, they are like methotrexate, leflunomide, mycophenolate, tofasnib, rituximab. They are safe in male paternal safety. They are good and safe. And coming back to our patient is clinically there are no features of SLE. Labs are normal, C3, C4 normal. APLA workup LAC is positive, and ANA profile was negative for anti-SSA, and patient is on MMO. Therefore, what you have to do, you have to change MMO to a non-teratogenic drug. As I told, azathioprine may be a good drug. It's a safe drug during pregnancy. Azathioprine plus usually we start folic acid 5 milligram per day, and you should slowly titrate the azathioprine. It doesn't mean that you suddenly stop and give full dose of azathioprine. We have to titrate, gradually increase the dose of azathioprine, because azathioprine also, those who have TQMT deficiency can cause severe bone marrow suppression. Start slowly and increase. And once they reach a full dose of azathioprine, usually the maximum dose allowed in pregnancy is 2 milligram per kg per day. Patient should be on a stable dose of azathioprine for at least 6 months to see that whether the patient getting flares on azathioprine. Because we are changing a drug where patient was stable on MMO, and we should also assure that patient will be stable on azathioprine also. And you should add low dose aspirin because LAC is positive. And prednisolone and SCQ should be continued. And antenatal checkup, it should be managed like a high-risk pregnancy. There should be a monthly, as a rheumatologist, I used to do a monthly review. And ideally, as per the guidelines, the obstetrician also should do a monthly review till 20 weeks. Then they say, guidelines say that every 2 weeks you have to see, and after 28 weeks, every weekly. And lab investigations, routine investigations should be repeated every monthly, and C3, C4 once in 3 months. And there are some caveats in this. ESR can be falsely high in pregnancy as pregnancy advances. But C3, C4 is an indicator of disease activity. If it is low, you mean that patient may have an active disease. And sometimes it will be difficult to differentiate a pre-eclampsia or a pregnancy complication from SLE flare. How to go ahead? In pre-eclampsia, due to a pregnancy complication, C3, C4 may be normal. And high DS-DNA titers, that shows a more likely chance of SLE lupus flare. And proteinuria can be present in both pre-eclampsia and lupus flare, but active urinary sediments like RBCs, RBC cast will be present in renal flare. And also look for other features of SLE disease activity. Our patient had an unequal antenatal period, delivered a healthy baby. However, during the postpartum period, she had a severe flare in the form of bilateral period edema, frothing of urine, urine short RBCs, urine albumin of 3 plus RBC cast, creatinine went up to 1.6. It's a major lupus renal flare. How to manage this case? You have to treat aggressively for this active lupus nephritis. Ideally, a renal biopsy is needed, but patient refused it. What are the options? You should give hydrosteroids plus cyclophosphamide, MMF, or rituximab. And cyclophosphamide, MMF, as I told, is contraindicated in lactation. Therefore, rituximab is the choice. We treat it with hydrosteroids plus rituximab, and azathioprine was continued. If you are giving hydrosteroids, or pulse, steroids more than 20 milligram per day, usually it's recommended to feed 4 hours after the dose to reduce the infant exposure. This in summary, basic preconception, you start planning from the preconception itself. And the active SLE at the time of conception is the strongest predictor of adverse pregnancy outcomes. Studies are, you can see that previously the fetal loss was 43%, nowadays the percentage has easily come down. Coming to the other disease in autoimmune diseases, rheumatoid arthritis, actually it's a good that when a patient becomes pregnant, RA disease actually comes down. But however, during the postpartum period, there is a high risk of disease flare, arthritis flare. Therefore, it should be properly counseled to the patient. And the goal is to well control the rheumatoid arthritis before conception, at least 6 months. And all patients of rheumatoid arthritis also should be screened for anti-SSA antibodies by doing ANA profile. And spondyloarthritis, psoriatic arthritis, not much affected during pregnancy, and pregnancy is also not affected due to the disease. However, there can be physical limitations if there is a hip joint involvement. There will be difficulty in a normal delivery. And systemic sclerosis, in general, the fertility is preserved, but pregnancy is considered high risk due to maternal complications, especially a patient has ILD, it can worsen, and it is a very severe ILD, it is contraindicated. PH is pregnancy is contraindicated because scleroderma can have PH and ILD. And scleroderma, risk of scleroderma renal crisis, although it's very rare, that means the patient can have a very high BP and a renal failure. It is increased during pregnancy. And the GERD, gastroesophageal reflux disease, increase. It's a well-known complication of systemic sclerosis. It can worsen during pregnancy. And in the initial 3 years of disease onset, it is usually advised to avoid pregnancy in systemic sclerosis. And primary Sjogren's syndrome, MCTD, should be managed like same as SLE, although the risk of pregnancy outcomes, worse outcomes are less when compared to SLE. Coming to the Takayasu arthritis, in general, rule is that as other autoimmune diseases, pregnancy should be attempted only in remission for at least 6 months. The main issues are the systemic hypertension. Takayasu arthritis is associated with systemic hypertension, increased risk of preeclampsia, and it's also not pulseless disease. Therefore, it's difficult to sometimes monitor the BP. Sometimes you have to look for the lower limb BP because upper limb pulses may be absent. And IUGR is risk of IUGR increase, especially the abdominal aorta or the uterine artery is involved. Sometimes some patients of osteoarthritis can have AR, severe AR. There is the risk of cardiac failure, so you have to do a pre-conception echo. And in osteoarthritis, it said that there can be coexistent APLA. Therefore, you should screen for APLA also in osteoarthritis. What happened to some patients? Sometimes you come with a pregnant, they did ANA, it came as positive. They did because their sister or some relatives was diagnosed of SLE. Just ANA positive doesn't mean a patient have a high risk of autoimmune diseases or worse pregnancy outcomes. Around 10 to 15% of the healthy individuals can have ANA positivity. Basically, the clinical context is very critical. If patient have symptoms, if you have to ask for the symptoms, asymptomatic, generally benign. You have to also ask for the method because ELISA can have a lot of false positive. The gold standard is the indirect immunofluorescence. Titer is important, 1:80 titer. And intensity is also important. 2% above is considered significant. And sometimes some patterns means that a dense fine speckle pattern. It's also called DFS 70. It is considered benign. But if a patient has other patterns and in pregnancy, even if it comes as accidentally positive, you have to check for ANA profile to look for anti-SSA-SSB antibodies. Because many of these patients can be asymptomatic. Their first manifestation may be the fetal heart block. They may pick the disease while the patient presents with the fetal heart. Therefore, in SLE, in pregnancy, when ANA comes as positive, you have to check for an ANA profile. And take-home messages, you have seen how the autoimmune disease affected the pregnancy and vice versa. It varies. And pregnancy worsens SLE, whereas it may improve rheumatoid arthritis. All lupus pregnancy should be considered high risk and monitored closely. Pre-conception planning is essential, and pregnancy should be planned when disease is in remission for at least 6 months. And the care starts before conception until the postpartum period. And drug safety knowledge is evolving because I told that in paternal safety of methotrexate, previously it was considered that methotrexate should be avoided in the males who are planning to become father. And the most pregnancies in patients with autoimmune diseases, if carefully monitored and appropriately treated, can result in healthy children. Thank you for patience.
Thank you, Dr. Midhun, for that excellent presentation. I would like to ask you one question. You said about switching over the immunosuppressants to azathioprine before when you're planning for pregnancy. What if the patient accidentally becomes pregnant while on these immunosuppressive? How do you proceed with this?
Whatever I talked was basically about the ideal scenario. Whatever we will tell the patient sometimes come with this, I have become pregnant, accidentally become pregnant. For example, patient on mycophenolate mocktail, there is a risk of teratogenicity. Therefore, medical legally, it is very important to document that patient has received mycophenolate and there is a risk of teratogenicity. You should, in case of mycophenolate, the human studies actually doesn't show much of teratogenicity. And in a low dose mycophenolate. If you are getting a 500 milligram BD, the risk is less, but still the risk will be there. Therefore, if patient accept that risk and continues with the mycophenolate, but this happens only if patient comes early. If patient's on mycophenolate and comes after 3 months, nothing we can do. There is a definite risk of teratogenicity. If it comes very early, then as a shared decision, we may plan to continue mycophenolate mocktail. And methotrexate, although I said it is 3 months, latest guidelines say that even up to 1 month exposure, or we can stop at least 1 month prior. Because methotrexate, the dose we use is much less, and the teratogenicity is very less in our dose. That means low dose methotrexate is less. Therefore, the guidelines also say that if you are exposed to methotrexate very early in pregnancy, And many studies also shows that the outcomes are not that bad as we thought before. Therefore, you have to tell the patient, you have to take a shared decision with we have to document everything. Medical legally, if something happens, then we'll be in trouble. Ideally, it should be stopped 6 weeks prior.
One more question is that you discussed about the low dose aspirin with low molecular weight heparin. So, do you continue it through the entire pregnancy?
Yes.
And how often have you come across any complications related to these drugs when you continue for long?
No.
Sometimes these patients can develop thrombocytopenia due to SLE disease activity itself. In that case, sometimes it may be very difficult to continue aspirin and heparin. In those cases, we have to manage accordingly. Otherwise, due to heparin alone, we have not seen much complications.
Midhun, thank you for giving awareness about the investigations. One query with me is actually, we have seen cases at 22 weeks and 16 weeks with one with the HELP syndrome, which is a pre-viable period. And also recently we had a case with pro-PNB, more than 1,600, and patient had cardiac features of dyspnea. And we terminate the pregnancy. Is it SLE flare, or where we need to wait for C3, C4? Even if C3, C4 is SLE flare, is there any indication for termination?
It can be a very early in pregnancy, it may not be HELP syndrome at all. Sometimes it can be a SLE flare itself. If you see the SLE, the pathogenicity, like if you do a peripheral smear in severe HELP or CAPS, like a catastrophic APS, they all show what histiocytes. Therefore, if you said 14 weeks of pregnancy, 16 weeks of pregnancy, if patient have a low C3, C4, that again says that patient is likely having a very active disease.
The BP is high and enzymes are elevated. Actually, it's a pre-viable period. For the sake of the mother, we have terminated the pregnancy actually. If it is SLE...
One of the treatment of SLE, severe SLE during pregnancy is termination of pregnancy. Once you terminate the pregnancy, sometimes we can save the lady also.
I have actually these patients I have sent to you. And another one more is cyclophosphamide when the patient is on. Actually, it reduces the fertility by the AMH value will be, it will affect the ovarian reserve and also HPA axis. So what the fertility the doctors do is they give GnRH agonist along with
2 weeks prior to cyclophosphamide, usually we offer them gonadotropin.
And most of the cases I have seen is with a long elderly woman after IVF treatment spending too much with lakhs of money and they conceived and then come with this problem. You are recommending for this woman to do the antibody test before they go for IVF?
Which antibody, ma'am?
See, we have seen cases, elderly patients, 46, 48-year-old, after IVF treatment, they are coming with these problems, early onset preeclampsia, we need to terminate, we need to counsel the patient, so much of concerns are there. Actually, are you recommending these patients?
I think there are not such recommendations. All patients screening with ANA, I don't think.
And because they are spending lakhs of money and then they have to terminate the pregnancy, it's very quite traumatic experience.
I think our patient had history of lupus nephritis. Even if the patient was in remission for the past 6 months, I think one history of lupus nephritis is itself a risk factor for lupus flare in the pregnancy. Probably that was the reason for her flare postpartum, isn't it?
Lupus nephritis means that patient is having a very severe SLE. Patient had a severe SLE because there are mild SLEs and severe SLEs. Therefore, if patient is in remission for 6 months, the risk of flares will come down. It is not absolutely no. It's 0%. Risk is still there. It can either flare during the later part of pregnancy or in the postpartum. But it can flare not only in the form of renal flare, it can flare in the form of other forms like autoimmune hemolytic anemia, thrombocytopenia, other forms also.
Okay. Another is regarding the dosage of this low dose aspirin. There are some experts who tell that at least there should be 100 milligrams of aspirin.
That is basically based on a trial, RCT on eclampsia. To prevent eclampsia, they have used 150 milligram per day. They are compared with placebo. They are not compared with 75 milligram. In APS, most of the studies are on the low dose aspirin, 75 milligram to 100 milligram. Therefore, the guidelines say that 75 to 100 milligram is enough for no need to give a 150 milligram as per the guidelines.
A minimum of 100 milligrams is required. That was some of the
Low dose
experts'
aspirin
view.
by definition
That's-
is 75 to 100.
When there is preeclampsia risk.
Pre-eclampsia,
Yes,
that
actually
study
in the
showed used 150 milligram.
Yeah, first trimester screening is possible. For these patients, ideally, they have to undergo the screening by the MAP and also the NG and the biochemical markers.
Why they are-
And uterine artery Doppler, which is increased resistance. That is,
A higher dose of aspirin.
Yeah,
no?
Higher dose of-
Higher
150
dose of
milligram.
aspirin is based on that data, on eclampsia study. 150 milligram per day, that came in NEGM.
We are giving
That
routine.
actually reduce the risk of eclampsia.
Yeah,
But they have not compared it with 75 milligram per day.
As
Therefore, we
per
cannot say that 150 milligram per day is better than 75 milligram per day.